Hello folks, our next developmental white disorder to discuss will be keratosis follicularis, which is eponymously also referred to as Darier's disease or Darier-White Syndrome, to acknowledge two of the individuals involved in the initial discovery and first descriptions of the disorder. You may also come across terms like ichthyosis follicularis and dyskeratosis follicularis. In our discussion today, we will stick to the eponym Darier's disease, as it's a much more common name used worldwide for this condition. It is a very diverse pathological entity having different modes of clinical manifestations, which can make its diagnosis quite challenging for clinicians and indeed for histopathologists as well. It is one of those pathologies where if you do not think of it, you probably will not diagnose it. It is primarily a skin disease, which means that dermatologists will more frequently see these patients rather than dental or oral medicine specialists, unless of course there is a significant intraoral involvement. Here is a case that mimicked a herpes zoster shingles eruption, and in fact, this patient was repeatedly yet unsuccessfully treated for shingles using antiviral agents. A biopsy was then performed sometime down the line, which revealed histological findings suggestive of Darier's disease, and a diagnosis of zosteriform linear variant Darier's disease was made, and therapy was initiated promptly using oral retinoids and topical steroids with a good response and clinical outcome. Note that this form of Darier's disease, unlike the classic form, which we will focus on for the remaining of the discussion, is usually not inherited, and this can further add to the difficulty in making the diagnosis. It is thought to arise from a post-zygotic somatic mutation. For the purposes of this discussion, however, overall, we can generally define Darier's disease as a spectrum of inherited keratinopathies manifesting with skin and nail lesions and exhibiting varying degrees of mucosal involvement. By spectrum, I refer to the fact that there are various clinical phenotypic expressions of the same disease, from localized variants to variants or subtypes that have tremendous impact on quality of life, with some cases even being linked to a number of neuropsychiatric disorders. Quite like white sponge nevus, multimucosal involvement may occur: oral, pharyngeal, laryngeal, esophageal, and anogenital areas. The classic pathology at these sites will often present as white keratosic papular lesions that may coalesce in severe cases to form plaques and mucosal cobblestoning. Among these sites, the oral mucosa is the most frequent mucosal site. It is capable of affecting any area of the mouth, so that in extreme cases, the oral surfaces become rough and lumpy. In fact, in a handful of cases or so, oral mucosal lesions may be the only clinical sign that Darier's disease is present. When the gums are severely affected, patients may present with gingival enlargement, but these are exceptional and uncommon scenarios. Some cases are associated with salivary gland obstruction, and this has been attributed to secondary periductal fibrosis and severe squamous metaplastic changes in the ductal epithelium. These salivary swellings are intermittent and can involve both major and minor glands, the outcome of which is a functional deficit producing secondary changes in the oral cavity, things along the lines of dry mouth, burning oral sensations, advanced periodontal disease, candida oral infections, and so on. Now, let us look back at our very useful table from the Whitcomb's discussion, so we can compare and contrast characteristics of Darier's disease with these other developmental disorders of keratinization. In Darier's disease, without considering the unusual linear or zosteriform variant we looked at a while ago, we can say that it is also generally an inherited genetic disorder, and it has an autosomal dominant mode of inheritance. So here as well, the affected parent will have a 50% chance of passing down the disorder to the child, of course assuming that that parent is only heterozygosly affected and not homozygosly affected. Being homozygous for an autosomal dominant disorder will mean that all of the offspring of the affected individual will have a mutant allele that is capable of expressing phenotypes of that disease. So effectively, that projects to a 100% chance of passing down the disorder, rather than a 50% chance as will have been the case in a heterozygous state. Thankfully, homozygotes for human autosomal dominant disorders are very rare. The only one disease that I can think of that could have that characteristic is Huntington's disease, but then I am not a geneticist, so I will not comment further on that. There could probably be more than one. Nevertheless, Darier's disease is heterozygosely inherited autosomal dominant genetic disorder with a high but incomplete penetrance and variable expressivity. Well, that brings us again to the issue of heterozygosity, because incomplete penetrance and variable expressivity are phenomena of Mendelian genetics that are possible because the normal allele in the heterozygous pair may influence the overall outcome of the disease, at least in terms of phenotypic expression. In addition to other genetic and environmental modifiers, it may partly substitute for some of the function of the mutant allele, thereby ameliorating the overall disease process. On the other hand, homozygous dominant disorders will most likely always display complete phenotypic dominance, as there is no normal gene, at least locally, to compensate for the function of the abnormal gene. Note that variability in expression of genes is closely linked to incomplete penetrance, and the two phenomena lead to non-linearity between genotype and phenotype. So essentially, having a disease genotype does not necessarily mean that one will exhibit the complete disease phenotype. Anyways, let's continue with the table. Darier's disease is characterized by oral, cutaneous, as well as hair and nail involvement, often in a bilateral and symmetric presentation. Whereas oral lesions tend to be largely symptomatic, the skin lesions are usually intensely pruritic and often painful. These lesions have been described to occur in so-called seborrheic and intertriginous areas, which are essentially oily body parts where sebaceous glands and their secretions are abundant. The face, scalp, the axilla, chest, submammary areas, the groin, umbilical, and perianal areas. The lesions start showing up in the first and second decade of life and tend to vary in severity as the individual matures, often becoming more diffuse with age. They may also undergo alternating cycles of remission and exacerbation at various stages of life. The lesions can be scaly and crusted, and when these patients sweat, the lesions become moisturized, which then becomes a perfect habitat for microbes. This explains the extreme unpleasant smells that is associated with these lesions. Now, although a few studies have shown a slight male predilection for Darier's disease, the majority have found out that males and females are affected equally with no special gender preference, just like in white sponge nevus and Wittkopp's disease. Again, like white sponge nevus, multiple mucosal sites may be involved as well, even the eye, which may present with corneal epithelial lesions and varying degrees of corneal opacity following thickening of the lining epithelium. In fact, a referral for ophthalmological examination should be part of the management process for Darier's disease. Some other common ocular findings include things like blepharitis and conjunctival hyperemia. Let me now point out, even though it might not seem like it, that overall, a large number of individuals with Darier's disease are left undiagnosed, not only because the diagnosis may be challenging to make, which it is in a number of cases, but also because the symptoms and signs are usually quite mild and unbothersome. Most patients lead normal and untroubled lives. The oral lesions in particular may only be observed following routine dental examinations. With that said, there are certain environmental factors that may cause aggravations in these patients, especially with respect to the skin lesions. Things like high temperatures, ultraviolet exposures, humidity from sweating, high stress, and infections. In fact, the skin problems in these patients make them increasingly susceptible to infections, which again is responsible for the malodorous characteristics of the disease. Bacterial, fungal, or even viral infections can all complicate these lesions. To demonstrate how serious this can be, Let's quickly discuss the dreaded Kaposi's varicella eruption, or eczema hepaticum, sometimes also referred to as acute pustulosis varioliformis, as it resembles lesions caused by variola or smallpox, which of course has been globally eradicated in the 1980s, some 40 to 50 years ago. Eczema hepaticum is a widespread viral infection, caused usually but not always by herpes simplex viruses, both types 1 and types 2, in the setting of a pre-existing chronic dermatological disorder. For instance, atopic dermatitis, lupus, pemphigus, seborrheic dermatitis, Darier disease of course, and even malignant skin diseases like the cutaneous T-cell lymphoma, mycosis fungoides. It may also be caused by Coxsackie virus A16, the same virus responsible for hand, foot, and mouth disease. The underlying message here is that eczema hepaticum is a viral superinfection of a pre-existing skin disease and is characterized by an acute presentation of burning and painful skin and oral eruptions, accompanied by high fever and general lymphadenopathy. The lesions are typically blistering but tend to quickly break down, leading to large confluent ulcers, which sometimes involve almost the entire body surface area. The reason for these eruptions is possibly because of immunologic derangements caused by the pre-existing skin disease, thereby allowing the virus to cause such disseminated infections. Do not forget that the skin, or the keratinocytes for that matter, aside their innate barrier function, also provide a cellular type of immunity against pathogens, and indeed, the condition is made even worse in some patients if they are started on immunomodulatory agents that further retard cellular immunity. For instance, there have been reports of cases being precipitated by the calcineurin inhibitors, cyclosporin, tacrolimus, and pimecrolimus. Thankfully, it is readily responsive to antiviral therapy if initiated early. Starting therapy promptly is essential to reducing mortality and morbidity, and you should not wait for laboratory PCR results before commencing treatment, as this may take some time. Prophylactic antibiotics will help to prevent secondary bacterial infections, and patients are often treated in a hospital setting and given intravenous treatment initially. Things along the lines of IV acyclovir given together with IV clindamycin for a couple of days on the ward, and then if significant improvement is observed, patients will be discharged home on enteral treatments, oral acyclovir and oral doxycycline for another couple of days. Topical antibiotic ointments like silver-sulfadiazine or 2-pentatmipuracin may also be added to this therapeutic regimen. Now, let's move on to look at the underlying mechanism of Darier's disease. What is the molecular pathology and how much of it has been known? To try and explain this, let's first discuss briefly calcium metabolism in relation to the keratinocytes. Calcium regulation in mammalian cells is critically important for proper functioning of the cell, and a large number of ion transporters or pumps are available for this purpose. One well-studied ion pump is the P-type ATPase called SERCA, which transports calcium ions across the membranes of the sarcoplasmic and endoplasmic reticulum against a large concentration gradient. Each time an ATP molecule is hydrolyzed, the pump transports 2 calcium ions from the cell cytoplasm into the luminal space of the sarcoplasmic or endoplasmic reticulum, while at the same time transporting 2 or 3 hydrogen ions in the reverse direction from the reticular lumen to the cytosol. So actually, SERCA is a calcium hydrogen ATPase, and so essentially functions to ultimately regulate cytosolic calcium levels as well as sarcoendoplasmic pH. Within the keratinocytes, this controlled regulation is crucial for survival and optimal functional keratinogenesis. Free calcium in the cytoplasm of the keratinocytes is a powerful second messenger, acting directly or indirectly to control a variety of cellular functions, including things like gene expression, cell division, cell proliferation and differentiation, and the mechanisms of keratinocyte apoptosis. The free calcium also activates a number of potentially destructive intracellular enzymes, proteases, nucleases, hydrolases, lipidases, and many others. Within the endoplasmic reticulum, calcium is thought to be involved in the synthesis of components of the junctional complexes, so that in experimental studies, inhibiting SERCA pumps resulted in weak tight junctions and poor desmosomal assembly. The ensuing impairment of cell-cell adhesion results in epithelial acantholysis and floating cells that are observed to undergo apoptosis. And indeed, this is how the histologic picture of Darier's disease appears in a typical patient. Now, the specific form of SERCA that is abnormal in Darier's disease is the second isoform, SERCA2, and the underlying molecular mechanisms involve loss of function mutations in the encoding gene on the long arm of chromosome 12. These mutations may be missense, frame shifts, nucleotide deletions, insertions, or nonsense mutations, and could occur sporadically without being inherited or inheritable. Here is the structural complex of the human SERCA2 isoform. The details here are not as critical, but you should at least be able to have a visual idea of the big picture. It is a large transmembrane protein with cytosolic domains, membrane-spanning alpha helices, and luminal domains. Here is the N-terminus, and here on the right side is the C-terminus. You should note that there are 3 alternate splice variants of SERCA2, giving rise to a SERCA2A, a SERCA2B, and the more recent discovery of a SERCA2C. The structure I am showing here is a SERCA2B variant and is a specific splice variant that is non-functional or dysfunctional in Darier's disease. You can see that there are 11 membrane-spanning alpha helices. This 11th alpha helix, M11, is specific to the SERCA2B variant and is absent in the other 2 SERCA2 variants. For instance, in SERCA2A, you have it replaced by a short sequence of 4 amino acids: alanine, isoleucine, leucine, and glutamic acid. In SERCA2C, you will find a replacement of 6 amino acids: valine, leucine, 2 serines, a glutamic acid, and another leucine. It is only in SERCA2B that you have an enough length of this N-terminal sequence of 49 amino acids so that it falls into another transmembrane alpha helical domain that further extends into the lumen of the endoplasmic reticulum with a total size of 1043 amino acids. This proline is a point of divergence for these 3 splice variants, and the C-terminal differences could explain the functional disparities, especially between variant 2B and the others, so that a spliced SERCA2B, which is again the specific Darier's variant, has a higher affinity for calcium ions. It is also the most dominant variant expressed in keratinocyte ER organelles. The other variants are mostly expressed in muscle cells. Mutations that occur in SERCA2B and result in a Darier's phenotype are many and scattered throughout the structure. Let me point out at this time that in a very closely related disorder of Darier's disease, acrokeratosis verruciformis of Hoff, a specific amino acid change occurs here at position 602, wherein this proline is replaced by a leucine. In any case, the result is a reduced calcium level in the ER lumen coupled with a high cytosolic concentration. This is because the mutations in one way or the other affects the calcium uptake activity of these pumps. This obviously depends on the degree of haploinsufficiency, or how much of the normal gene can compensate for the abnormal gene. In fact, some mutants have actually led to the suppression of the function of normal co-expressed SERCA2 pumps. This is important because then there is a limited degree to which the abnormality can be compensated for, hence ultimately leading to a high phenotypic expression of the disorder. Now, the resulting low intra-ER luminal calcium levels affects the correct processing of freshly synthesized proteins, and in keratinocytes these proteins include not only keratins but also proteins necessary for forming adhesive contact between cells. Again, this explains the acantholysis and also the dyskeratosis observed in Darier's disease. Also, this reduced calcium level in the ER lumen, coupled with a relatively increase in cytosolic concentration, leads to a compensatory upregulation of a plasma membrane protein known as TRPC1, a transient receptor potential channel which is thought to exert a pro-survival and sustained proliferative influence on keratinocytes. The upregulation of this channel has been demonstrated in cell culture experiments as well as in actual Darier's disease patients. So effectively what we've said so far is that the low intrareticular calcium level somehow upregulates TRPC1, which then sustains the already hyperactive signaling pathways initiated by the high intracytosolic calcium as a result of a failure of the SERCA2 pump. Remember that calcium is an important second messenger. The physiologic intent of the TRPC1 upregulation is to mediate calcium influx from the extracellular space into the cell cytoplasm so that it may then be transported into the ER to replenish depleted stores caused by a non-functional SERCA2. But obviously, without SERCA2, without a functional SERCA2, the cell cannot concentrate calcium into the ER, which means the cytoplasm maintains an even higher calcium concentration, and the consequence of this should now be obvious to you. TRPC1 is a store-operated calcium entry protein, which essentially means that the activity is dependent on the state of intracellular stores of calcium, such as the endoplasmic reticulum. Isotretinoin, which is one of the drugs used in treating Darier's disease, is thought to work by reducing the activity of TRPC1, thereby decreasing calcium influx. It is classed as a SOCI antagonist, a store-operated calcium entry antagonist. So, what we have now is we have looked at a really brief overview of the molecular pathology of Darier's disease, and hopefully this can help you explain or understand some of the clinical features we observe in this disorder. These features may include things like warty-like lesions, hyperparakeratotic papules, and brittle nail defects such as these porous and wedge-shaped abnormalities. These lesions may be widespread and, as we mentioned earlier, may go on to be a perfect depot for anaerobic microorganisms, especially long-standing unremitting skin lesions that get moisturized by sweat. These microbes will constantly release aromatic volatile metabolites that cause unpleasant bodily odors, and this can greatly affect all aspects of the social life of the affected individual. To counteract this issue, topical antimicrobial applications, for instance, 1% metronidazole gels applied regularly, coupled with a good body hygiene, may help to control this problem, which for a number of patients can be very embarrassing. Now, we've mentioned not too long ago also that the molecular mechanisms we looked at can help us to understand the histologic picture of Darier's disease. To that effect, we can now list the histological signatures of the disease to include the presence of thick ortho or parakeratosis, suprabasal acantholysis from desmosomal keratin disintegration, abnormal keratinization or dyskeratosis, and rounded and slender apoptotic keratinocytes, which are described as chorons and core grains, respectively. These are indeed variants of these keratocytes. Also, the histology may show a moderate to intense subepithelial chronic inflammation and sometimes bacteria within the epithelium, the same ones responsible for causing body malodor in these patients. The overall histologic pattern is an acantholytic form of dermatosis, and indeed, it shares features with other diseases having similar underlying molecular pathology, such as the autosomal dominant Hailey-Hailey disease and the acquired Grover's disease. Hailey-Hailey disease is caused by mutations in the gene encoding a specific type of calcium ATPase in the membrane of the Golgi apparatus. The affected protein pump is also mostly active in keratinocytes, so these patients also not surprisingly develop acantholytic skin lesions. By the way, acantholytic dermatosis essentially means that the epithelium begins to fall apart as a result of disc cohesion from the breakdown of desmosomal contact, which in our case is a direct or indirect consequence of a failed calcium ATPase pump, SEDCA2B. One component of the desmosomal complex affected by this SEDCA2 dysfunction is desmoplakin, which normally is responsible for linking cytoskeletal proteins to the desmosome in order to help maintain cell-to-cell cohesion. I've listed here pemphigus vulgaris because it is also characterized by severe acantholysis, but the mechanism here is an autoimmune attack of desmoglein 3, a component of intercellular desmosomal junctions, which is also calcium dependent. Now, here are the chorons, rounded disc keratocytes, and the grains, slender disc keratocytes. Now, one variant of Darier's disease you may have to know is the oral warty disc keratoma, or focal acantholytic disc keratosis, which is mostly seen to occur on the hard palate and alveolar region and has similar histological features as Darier's, though you may observe more villous projections and papillomatosis with loss of lymphoplasmacystic infiltrations. Chorons and core grains are also characteristic. The treatment is simple excisional surgery and follow-up. For Darier's disease, however, treatment is not quite as straightforward. In fact, there are different degrees of severity in terms of clinical manifestations. So whereas some individuals may experience chronic and unremitting, morbidly devastating lesions, others may be asymptomatic and lead normal lives. Again, as I've mentioned here countless number of times, this all depends on the extent to which the normal SEDCA2 gene in the allelic pair can compensate for the malfunctional protein within keratinocyte EL membranes. It turns out that males tend to be more severely affected than females. In any case, a multidisciplinary approach to management is highly recommended to tackle the oral disease, the dermatological manifestations, the psychosocial impact, counseling from geneticists, pain management specialists, and infectious disease experts. As you mentioned previously in passing, medical treatment now employs the benefits of topical and systemic retinoids such as isotretinoin, etretinate, adapalene, which in addition to being a SORC antagonist, also promotes keratinocyte differentiation and stability. But the side effects of these agents, especially the teratogenic effect in females of childbearing age, make their use restricted for only a selected number of cases. Also, their chronic use may result in hyperostotic skeletal abnormalities and may inhibit growth of children. To go around these side effects, some cases have managed and had some success with immunomodulating agents, steroids and the steroid sparers like tacrolimus and pimecrolimus. Some resistant lesions may respond to laser ablation or keratolytic agents. One recalcitrant case has benefited from the use of low-dose intravenous immunoglobulins. One explanation, or at least a theory, that I can give for this is that by inhibiting the abnormal SEDCA2 pumps with these immunoglobulins, he also relieved their suppressive effect on normal wild-type pumps, which may then compensate for the functional losses. Lesions that are puritic may be calmed with antihistamines in an effort to prevent scratching and further damage to the skin. Of course, and I cannot stress this enough, that in all of these instances, it is critical that a superimposed infection is avoided or promptly managed so as to prevent the dreaded Kaposi's varicella phenomenon. Wearing of cotton clothes keeps the skin dry, so moisture does not encourage microbial growth. Patients also should avoid or limit their exposure to environmental factors that may exacerbate these lesions. For instance, a direct instruction to avoid UV light is recommended for some of these individuals. Also, as you might expect, the use of calcium channel blockers such as diltiazem for hypertension or ischemic heart disease has been reported to worsen the Darier's phenotype and should be avoided in these patients. The oral lesions in Darier's disease overall do not usually require specific treatments.